From the Journal of Nuclear Cardiology, this is JNC Cardio Connect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Hello, and welcome to a new episode of JNC Cardio Connect. I am Marcelo Di Carli. I'm the editor-in-chief of the Journal of Nuclear Cardiology. And today I convened a group of experts in the field of nuclear cardiology to have a conversation about radionuclide perfusion imaging, especially in light of the fact that we have a recent milestone in our field and the approval of a new radiopharmaceutical. So with me today, we have Dr. Panithaya Chare, who is the president of the American Society of Nuclear Cardiology. She's a professor of medicine at Mayo School of Medicine and the director of nuclear cardiology at the Mayo Clinic. We also have Krishna Patel, who is assistant professor of medicine at Mount Sinai School of Medicine and the director of cardiac PET at Mount Sinai Hospital. And my good friend and colleague, Dr. Rob Binlands, who is president and CEO of the Ottawa Heart Institute and a past president of the American Society of Nuclear Cardiology. Welcome to all of you, and thank you again for agreeing to being part of this conversation. I want to preface our conversation by providing a little bit of context for our audience. For more than 50 years, radionuclide perfusion imaging has been a transformative tool in the management of our patients with coronary disease. And over this time, we have witnessed, I think, three eras that are very distinct. One has been the pioneering days of planar imaging in the 70s and 80s. Then the rise of SPECT imaging in the 90s and 2000s. And over the last 15 years, a steady transition to PET imaging. I think it's fair to say that while PET has shown significant relative growth in our field, the absolute numbers have remained relatively modest, largely due to limited access. And one of the primary challenges has been the significant investment required for FDA-approved radiotracers. As you all know, rubidium-82 was approved in 1989 and 13-ammonia in 2003. And now we have reached a new milestone, as I mentioned, with the approval of Flurpiridaz, which is a fluorinated tracer that will enable unit dose distribution. So in today's episode, we will have a discussion about how these advancements have shaped our field. And we're going to get the experts' opinion about how do we think this will evolve over time. I'm going to ask first for Panithaya to provide us a little bit of a summary of the main results of the trial that actually led to the approval of Flurpiridaz.
Thank you so much, Marcelo. First, I want to thank you for including me in this JNC podcast. It's a real honor and a pleasure to be here with you today alongside such esteemed colleagues. And this is really a very exciting time for the field of nuclear cardiology. And so I'm happy to summarize the Aurora trial, which was the landmark phase 3, part 2 international multi-center trial that was designed to look at the diagnostic efficacy and safety of Flurpiridaz PET myocardial perfusion imaging for detecting 50% or greater coronary artery stenosis using quantitative invasive coronary angiography as the reference standard. And importantly, there were 730 patients with suspected CAD. They all had both Flurpiridaz PET and SPECT MPI. All of them also had invasive coronary angiography. And so this design allowed us to look at the head-to-head comparison of the two modalities in the same individuals. And this enhanced the power and clinical relevance of the findings. The study had 3 independent blinded readers who interpreted all the studies. And I think the results were quite compelling. Flurpiridaz PET showed significantly higher sensitivity, just over 80%, compared to SPECT MPI at about 69% for 50% or greater epicardial stenosis, while specificity was comparable. And flurpiridaz then met both the co-primary efficacy endpoints as defined by the FDA. Also noteworthy was that flurpiridaz PET sensitivities were also significantly higher, and specificities were non-inferior than those of SPECT in women and patients with BMI of 30 or greater, and this will be discussed further. I think these are the populations that we have had challenges historically. And then beyond diagnostic performance, perfusion defects, size, severity, image quality, diagnostic certainty, and radiation exposure were superior with PET as compared to SPECT. And really, readers reported much greater diagnostic confidence. That was very important.
Thank you, Panithaya. This is a fantastic summary. Panithaya hinted at the fact that the superiority of PET was not just for the entire population, but it was also present in specific populations that present, in many cases, challenges for SPECT imaging. Krishna, you were the lead author on a review that will be published in the Compendium for JNC, which will be simultaneously published with these podcasts. So can you give us a little summary of what you found to be the evidence in these special populations?
Absolutely. And thank you again, Marcelo, for having me over on this podcast. There were 3 pre-specified subgroups that were noted in the 2 phase 3 trials. Women was the first important subgroup, obese individuals, and then patients with diabetes. And historically, these are the subpopulations where we've had concerns about image quality and diagnostic performance. So let's start with women. In women, we're really concerned about breast tissue attenuation affecting image quality and diagnostic performance with SPECT. Between the 2 phase 3 trials, the 301 and the Aurora study, there were a total of about 430 women that were enrolled. And the results really mirrored the results of the overall trial, where sensitivity of flurpiridaz and specificity exceeded the predetermined thresholds, and the sensitivity and diagnostic accuracy was significantly superior in women with flurpiridaz PET compared to SPECT. Specificity was again non-inferior, but if you look at the numbers, it was higher with PET compared to SPECT. In obese individuals, we always worry about signal degradation due to soft tissue attenuation and radiation exposure. So in both these trials, a little over half of all individuals were obese with a BMI of 30 or greater. And again, the results mirrored the results of the overall trial population, where sensitivity was superior with flurpiridaz PET compared to SPECT, and specificity was non-inferior. Importantly, in obese individuals, you always worry about their diagnostic performance deteriorating with increasing obesity, as is what has been shown with technetium SPECT if you don't use attenuation correction or newer techniques. There was no evidence of that. The diagnostic performance and diagnostic accuracy was comparable in non-obese as well as obese individuals with flurpiridaz PET. And radiation exposure was in the 6 millisievert range compared to about 11 to 13 with technetium SPECT. Now, regarding diabetes, this is a high-risk population which is at a high risk for having coronary artery disease, frequently has multi-vessel coronary artery disease, often less symptomatic. So sensitivity, again, in detecting coronary artery disease is key in these individuals. The second phase 3 trial, the Aurora study, included diabetes as a subgroup, so we have information from that. Again, sensitivity was superior with flurpiridaz PET compared to SPECT. Specificity was comparable. And while the diagnostic accuracy did not meet the statistical significance, it was because the number of patients was relatively low. It was only about 30% of the population. So overall, the data in these 3 subgroups really look promising as far as diagnostic performance of flurpiridaz PET goes in these individuals.
Thank you very much, Krishna. That was an absolutely great and very informative summary. Rob, one criticism of PET over the last many years since it started is that because we were using short-lived radiopharmaceuticals, it was very challenging to couple PET with exercise. I know the data is somewhat limited, but tell us your thoughts and what can be done with exercise and what are the opportunities for the field of nuclear cardiology with exercise PET?
Thanks, Marcelo, for inviting me to this podcast. And I also want to say that I'm honored to be doing this with my esteemed colleagues, Dr. Chare and Dr. Patel. I'm also very excited about the compendium that's being published, and I do want to acknowledge the paper that relates to exercise and PET imaging, which really was championed by Dr. Chare and Dr. Burke, as well as Dr. Berman. I have to say that one of the most exciting things to me about Flurpiridaz is the ability to do exercise with PET imaging. Now, like you pointed out, it's not to say that rubidium and ammonia and also water in Europe, water, of course, is not FDA approved in the United States and is not approved in Canada. So all of these three tracers have been used with exercise, but with significant challenge because of their short half-life. This has really been a disadvantage compared to SPECT imaging with the technetium-based agents, where you have a longer half-life and you can image comfortably with exercise. It's important to recognize that exercise does have some important advantages in terms of assessing patients with symptoms. You have the ability to actually reproduce the symptoms themselves with physical stress. And this is important because it helps you with the diagnosis of the symptoms of the patients. As well, we know that ECG changes have added incremental value with perfusion imaging with PET. That's well known. We know that patients with low workloads compared to high workloads have a significant difference in the amount of ischemia that often is represented. We also know that the hemodynamic response, including the drop in blood pressure, can signify multivessel disease. The heart rate response is also associated with the lack or worsening the prognosis. The recent 2 phase 3 trials have assessed exercise imaging, and as we heard from Dr. Patel, the most recent one had about 17% of patients who did exercise. The preceding trial had about 26%. The preceding trial did show the superiority of sensitivity with exercise with similar specificity to SPECT. The more recent Aurora trial, it was not significantly different, but it was probably underpowered to be able to detect a difference. There was a numerical superiority of the area under the receiver operator curve for PET with Flurpiridaz over SPECT imaging. The thing about Flurpiridaz with its long half-life associated with F-18 means that you have the time to get the patient comfortably from the treadmill onto the camera to get imaging. One of the disadvantages of that is that you lose the blood flow capabilities, but we can talk about some of those challenges later.
Superb. Thank you. All three of you have really summarized in just a few minutes the entirety of the evidence supporting the utility of Flurpiridaz in perfusion imaging. So you alluded to some of the initial challenges as we rolled out Flurpiridaz into clinical practice. What do you think are going to be the main challenges, at least in the initial phase of this rollout?
So while I'm extremely excited about the exercise capabilities of Flurpiridaz, the data is actually fairly limited with only the 2 large trials and a couple of other smaller trials that have been done to evaluate it. So I still think we're going to need more data on it, but it's pretty promising, and I think there's a lot of SPECT data we can build upon in terms of its capability. Another thing that I'm concerned about, I think this is overcomable, but I think we have to pay attention to the fact that because of the excellent imaging capabilities associated with F-18 compounds and the tighter relationship to flow for Flurpiridaz's retention, we're going to see greater sensitivity for detecting mild disease. And I think we have to be careful about how we define that. And we're going to probably have a bit of a learning curve to understand these milder defects and potentially less hemodynamically significant coronary stenoses. We also probably need to better define who is going to benefit from exercise testing versus pharmacological testing. And as I mentioned earlier, one of the key limitations with exercise is that you're not going to get flow quantification. So that's why that decision making around who to exercise versus who you want to get flow reserve measurements on is going to be critical. I think Flurpiridaz will be a great help to centers who are doing a limited number of cardiac PET imaging because you can get unit doses and so on. It may pose workflow challenges for centers who do high volumes of PET, such as with rubidium or ammonia. So because the timeframes are a little bit longer, that's going to need to be taken into consideration. We're going to also have to pay attention to the distribution capabilities and the price point of the tracer. This may be a factor in how much is taken up in the United States, in Canada, in Europe, and elsewhere. All in all, though, I think all of these limitations can be overcome. And I think in time, this will be an important tracer that's going to contribute significantly to our ability to detect coronary disease, microvascular disease, and so on.
Fantastic. Thank you so much. Panithaya, what do you think is going to be the implication of these new evidence and new opportunities for the field of nuclear cardiology? And how do you think we're going to be using PET versus SPECT in the future?
Yeah, thank you, Marcelo. I think this is a very important question and one that really reflects where we are going as a field of nuclear cardiology. And we're at an inflection point. With Flurpiridaz, we now have the potential to move PET MPI beyond academic centers into the community because it's F-18 based. It overcomes some of the logistical barriers we've talked about. And we're no longer limited by generators and the need for an on-site cyclotron. So it becomes especially attractive if it can be delivered at a cost that supports broader clinical adoption. And there are still some logistical issues to work out with what Rob talked about with respect to protocols and deciding which patients should have exercise versus pharmacologic stress. So I think there are implications for broader adoption, a very exciting time for PET MPI. Having said that, SPECT MPI isn't going away anytime soon. It remains far more widely available throughout the world. And even in the United States, many sites face hurdles when it comes to PET infrastructure, training, and reimbursement. And so I think rather than framing this as PET versus SPECT, I see it as more of an opportunity to match the right test to the right patient. And so in centers where PET is available, I think it is a goal for us to think about it as the preferred modality, particularly when we have high BMI patients, women, in cases where image quality as well as myocardial blood flow quantification are critical. And we didn't really talk about flow quantification. It wasn't included in the main Aurora trial, but it is really the value proposition of PET MPI. And so I think that in the cases where flow quantification is critical in women in suspected high-risk patients, diabetes, where we think there may also be diffuse atherosclerosis. So in all those patients. But SPECT will continue to play an essential role, especially in settings where access and resources are limited. And so the key to moving forward is thoughtful implementation, education, and advocacy. And that's where organizations such as ASNC and journals like JNC play a vital role to help guide best practices, support training, and really help shape the conversation around value-based imaging.
Those are great thoughts. And I think it's a very good vision, what you emphasize about patient-centered imaging and trying to match the right test to the right patient. So thank you for that. Krishna, you'll have the last word here. And as you just heard, there are many unanswered questions, right? As good as the trials were in providing the evidence, we still have a lot of things that we don't know. Exactly how to use blood flow was just mentioned, and many other factors. So what do you think is going to be the main priorities for research focus as we try to position this new radiopharmaceutical in the field?
No, definitely. Thank you, Marcelo. I fully echo Panithaya and Rob's points that really we've just started exploring the research possibilities with Flurpiridaz, and there's really a lot of new and endless options and unanswered questions in this field. Up until now, most of the data that we have really is derived from the 2 phase 3 trials, which focuses on diagnosis of CAD. But the big question for us now is, how do these diagnostic results really translate into prognostic benefits over SPECT, or even changes in how we manage these patients? Given its fantastic tracer characteristics, I'm curious about how we can incorporate myocardial blood flow information in addition to the relative perfusion images with Flurpiridaz, and whether it is going to give us much more insight towards these other goals of prognosis and changing management than just perfusion imaging alone. We also need a lot more evidence in specific subgroups which are important, which were underrepresented in these trials. For example, patients with known coronary artery disease or complex CAD. The larger 303 trial did not include patients with known coronary artery disease. So we need to know how it performs in those patients. Other important subgroups that we need to look at are older adults, patients with heart failure, patients with chronic kidney diseases, other cardiometabolic disease. So really, there's a lot to explore there as well. Another really exciting area is stress-only PET with Flurpiridaz. With the longer half-life, now we have a nice window between the acquisitions where we could potentially review the acquisitions. That raises questions like, do we want to do stress-only cardiac PET? If so, for which patients might that be an option? And does it really make sense to skip the rest images and the flow information and all of that? So there's a lot to explore on that front as well. And on a broader scale, we understand the promise with Flurpiridaz and its availability at a unit dose, which is going to improve access to PET across the world. But we really need to figure out, now that we have Flurpiridaz, do we see an increase in uptake of cardiac PET being performed all over the world?
The three of you have made a masterful conversation, and you provided enough sound bites, hopefully to entice our readership to dig into the compendium that will be released at the American College of Cardiology meeting at the end of March. And the compendium will summarize all this evidence, but in greater detail, that people who are interested or are considering the possibility of embracing cardiac PET and think that Flurpiridaz may give them access to that technology. I think you want to read and learn as much as you can, and then take advantage of the many educational opportunities that ASNEC is putting together for training people how to deal with cardiac PET, how to read, learning about the pitfalls, etc. Once again, thank the three of you so very much. I really appreciate this conversation.